So I'm going to talk on glucose monitoring technology and focusing mainly on CGM and FGM. No financial disclosure to make for this talk. This is in 2013. Somebody had talked and published a paper in Critical Care. Quite simply, intermittent monitoring is not up to the task. We will be asking our nurses to target a discrete blood glucose range by using insulin, avoiding hypoglycemia, and minimizing glucose variability. This is what the task which we give to our ICU nurse or ICU resident doctor, that by intermittently monitoring the sugar, we should try to achieve a target glucose range without getting hypoglycemia and no glycemic variability. But we now have abundant data demonstrating that this cannot be accomplished safely or effectively by using meters, strips, or blood gas analyzer. Am I right? I'm sure all of you will agree that just by monitoring, even by doing it 2 hourly or 4 hourly, it's extremely difficult for us to achieve a tight glucose control. Moreover, we can be certain that these intermittent monitoring frequency do not detect every episode of dysglycemia that occurs in our patient. Successful management of all 3 domains of glucose control will require the use of continuous or nearly a continuous technology which can monitor glucose continuously. Now, we know that whatever the technology which is available to us, at present we can't use it in critical care, but this is a data, and as I told you in 2013, this paper was published in a critical care. Now, if we do the self-monitoring of blood glucose, most of our type 1 diabetic patients, they might be doing even 3 or 4 times in a day. And some patients who are put on insulin, type 2 diabetic patients, or intensively we want to control them, we are trying to do them on a self-monitoring of blood glucose. They may be on multiple daily insulin injection. And here you can see some patient who is monitoring the sugar maybe 4 times in a day, and almost every time you are seeing most of the sugar reports are normal, or we can say out of 4, at least 3 of them are normal. But if you do the continuous glucose monitoring, what you will find? You will find that in between, before the lunch, person is actually getting hypoglycemia. Midnight also the person is getting hypoglycemia, and as it was shown that post lunch or pre-dinner there was hyperglycemia also. So this is what a difference when we are doing a self monitoring of blood glucose and somebody is doing it.
Audio drive update kiya to ho gaya, I can hear it now.
The difference will be between continuous glucose monitoring and self monitoring. Manoj, I think you have to mute. Now, the difference between a continuous glucose monitoring or by a random glucose monitoring is like taking a photograph or a videograph. Like taking a videograph and photograph, you can see here the difference. It looks like a straight road, but actually there is a multiple zigzag, or it is actually a roller coaster type of sugar. The similar way, when you are taking one report on a random blood glucose level on a glucose meter, and when you do a continuous glucose monitoring, you will find a lot of glucose variation, or a lot of time the difference in the sugar reports also. It's like monitoring a ECG, which is a taking a photograph at that point of time. But if you do the Holter monitoring, maybe for another 3 days and 7 days, you may pick up many more things also. But how do we monitor our glycemic control? At this point of time, it is A1C. And before few years, it was only A1C. Rather, now we have many more devices to monitor our patients, but the A1C is the only. But is it enough for managing diabetes? You may have 2 different type of patients with a similar A1C, but these glycemic fluctuations have more problematic. They have more deleterious effect on endothelial dysfunction, endothelial function, oxidative stress, compared to a person who have less glycemic variability or less glycemic excursion. So focusing only on A1C may not reveal the complete spectrum of risk for people with diabetes. If you can have 3 different type of patient with the same A1C, one patient may have a time in range between 70 to 180, maybe 100% of the time, and other side of a patient who may have also A1C of 7, but still the time in range may be very little. He may have multiple hypo and hyperglycemia, still he may can achieve the HbA1c of 7, and other patient who have less hypoglycemia and less hyperglycemia peak, but still he is achieving also the A1C of 7 with 63% of the time is actually remaining in time in range. So I mean, there is a possibility that you may have A1C of persons same, but still the glycemic variability in all these three different patients on the same patients, maybe at three different times in a year, may have a different glycemic variability achieving the same A1C also. So the rationale for CGM is that CGM is especially beneficial for people who are not meeting their A1C goal. They have frequent low glucose level. They are unaware of their low blood sugar level. They want to reduce their A1C target without increasing the further hypoglycemic events, have widely variable blood sugar levels, and children or adolescents who are willing to use the device every day. And there, this technology should be useful, and will be very, very beneficial also. So the limitation of current monitoring method is, at present we have A1C, that's a standard of care, but the impact of hypoglycemia and hyperglycemia are unknown, because it is going to give you the average of last 3 months, and it will not be giving you any idea about the glucose variability of last 3 months. The self-monitoring of blood glucose will provide you glucose information only points in time, and at that point of time the sugar level is what? Most of the hypoglycemia unawareness or hyperglycemia peaks are often missed because they are asymptomatic. Overnight data is almost impractical, and logbooks, when the persons come with the self-monitoring of blood glucose, occasional glucose reports which are written on a rough paper, and it's really very difficult to interpret too. The continuous glucose monitoring is an advanced way of people living with diabetes to check the glucose reading in a real time, or monitoring the glucose reading over a period of time. So we have two variety of continuous glucose monitoring system which is available with us. Professional CGM, which is giving you the monitoring system, is a glucose monitoring device which is indicated for detecting trends and tracking patterns in persons with diabetes. It does not give you the real time. The persons come after 7 days or 5 days or 14 days, and we get the report of last 14 days or 5 days or 7 days. While real-time continuous glucose monitoring, it facilitates the persons with diabetes to be empowered to make much informed decision of managing their diabetes. They can see their sugar report continuously, and they can also take action, and if they are empowered to take the action for managing their diabetes too. Now, if we classify the CGM, actually it's not just two types. One, I already talked about the real-time continuous glucose monitoring. There is an intermittently scanned CGM. They say measure glucose level continuously, but it only display values when it is swiped by a reader or a smartphone. So that is what intermittently scanned CGM. That is what we have. Flash glucose monitoring. Again, as I talked about the professional CGM or a blinded CGM, when patient come back and we can see it. There is an integrated CGM. iCGM can be used as a part of an integrated system with other compatible medical devices and electronic interfaces, and which may include automated insulin dosing systems, insulin pumps, blood glucose meters, or other electronic devices used for diabetes management. Now, these are different CGM systems which are available to our country also. We have Libre, we have Dexcom, we have Medtronic systems. So we have almost all devices which are available, but there are many more devices which are available in the world. If you see the evolution of continuous glucose monitoring, the first generation, we never used it. It was not for the clinical use. The second generation, which had come from the Medtronic, which we had used in some of the patients, most of the places in the world now they are using the third generation, which have either wireless connectivity with the pump or on your phone. We have also the Dexcom, which is also on the phone, and we have Abbott now. Abbott is with Libre, Libre Pro, Libre 1, Libre 2, and now with Libre 3 also. The fourth generation are trying with the implantable sensors, which can be implants, can give you the continuous glucose monitoring. One sensor will give you the for 3, 6, or 12 months in use in time, and that is getting. And some of the some parts of the world it is already available. And the future of this will be a continuous monitoring. That will be fifth generation, a small CGM like a penny with a non-invasive monitoring, or an eye wearable, single use, fully disposable for intermittent use, and something like that will come in future. So probably that will be the future of this continuous glucose monitoring. But one thing is very clear, that whatever the continuous glucose monitoring technology which is available to us with just now, it is very much giving us a personalized care for our patients. It's a whether we use the professional CGM or a personal CGM. Personal CGM, the patients who can check their real-time sugar, but at the same time, they should be empowered for their action, and then we can have a very good control of the diabetes. Even with professional CGM, and patient come back to you after 5 days or 7 days or 14 days, you can make some changes and make the personalized care for that particular patient. The challenges with the CGM data, which was there with the Medtronic, which we had used in some of our patients before 10 years, but it was giving you this type of reports, while now the newer devices, which is ambulatory glucose profile or the Libre, which give you the report like this in a graphical form, which is much easier to interpret in compared to the previous report. Like this was really very difficult to interpret. Now it is much easy, because this is a software which is constructed from a model plot which collapses glucose data over several days or weeks. The data is plotted according to time as they have occurred over 24 hours. So all these data of 14 days is in this particular graphical form. Here you can see the dark line, which is like 50% of the time, or the median value is like this, and the light blue, and then there is a dotted line which is showing that even the 10% of the time the patient was either going here or here. So this is much easier to interpret. And now the other system of continuous glucose monitoring system, they have also started using this profile or this software too. Now the utility of continuous glucose monitoring in diabetic patients, if you see this paper in DCCT trial, which was completed in 1983, and it had shown the patient who were achieving the tighter glycemic control. The A1C of these patients, median A1C of these patients was 9, and they were achieving the median was around 7.2. But the severe hypoglycemia rate was 62 per 100 patients here at that point of time. Yes, definitely the NPH and regular insulin was available. They started for some of the patients even continue the pump also. For JDRF CGM, which was done in 2008, almost after 25 years, when they had used continuous glucose monitoring, yes, definitely newer insulin was used, but the mean A1C of these patients was 7.6, and they could reduce from 7.6 to mean A1C of 7.1. But you can see by using continuous glucose monitoring, the incidence of hypoglycemia is reduced from 62, which was there in DCCT trial, to 20 per 100 patients here. And while they were achieving the target of 7.1, and that too only from the mean A1C from 7.6 to 7.1, it was they were already well-controlled diabetes were getting further well-controlled diabetes, more controlled diabetes with the risk of hypoglycemia very less after 25 years. And it was all because of this continuous glucose monitoring device which they could use in this. There are a few studies which show that how CGM is better than SMBG. This is a Gold 3 study. The aim was to increase the understanding of continuous glucose monitoring, effect on hypoglycemia in person with type 1 diabetes who were treated with multiple daily insulin injection, and to improve the understanding of CGM effect on hypoglycemia confidence in daily life in this population. And what was the conclusion? The CGM reduced the time in hypoglycemia. It improved the hypoglycemia related confidence, and it improved well-being and quality of life also with these patients. There was one more study, Silver study, which is talking about the beneficial long-term HbA1c control and treatment satisfaction. Again, it was compared with CGM versus SMBG. The aim was to evaluate the effect of CGM in adults with type 1 diabetes. They were managed with multiple daily insulin injection, guideline-based clinical support over 1 year. And what they could see, there was a significant HbA1c reduction of 0.35 just by changing the monitoring system with a significant p-value, along with reduction in time spent in hypoglycemia and hypoglycemia fear, and increase in overall well-being, treatment satisfaction, and hypoglycemia confidence also. The Diamond study, the better glycemic efficacy and safety with CGM versus usual care, and what they had seen, that 18% of the CGM group had 4% of the usual care group had HbA1c level below 7%. So in compared to usual group, those patients who are on CGM were having better control and less than 7 with the significant p-value. The average duration of hypoglycemia was 43 minutes a day in patients who were on continuous glucose monitoring arm, in compared to 80 minutes in a day who were on a control group. So there is a significant reduction in A1C with a lesser duration of hypoglycemia in patients with continuous glucose monitoring. And we know that this is one paper which is talked about the real-time continuous glucose monitoring is better than FGM for patients who are type 1 diabetes. This is one of the trial which is corridor randomized control trial, which is talked that real-time is better in compared to FGM. So now we have a abundant grade A evidence which is published as far as type 1 diabetes is concerned. CGM is a standalone or in a sensor augmented pump. It had shown improved in glycemic control and less risk of hypoglycemia. Significantly, it improves pregnancy outcome in type 1 and it significantly increases the quality of life. So we have ample evidence to put it as a grade A evidence in type 1 diabetes patients by using CGM. CGM used in type 2 diabetes, yes. It also have the evidence to show that it significantly improves the time in range in type 2. There is a very significant additional impact on disease burden and very significant additional impact on cost saving on a long term too. This is one of the paper which is published from India in JAPI on a consensus statement. Can we use this FGM or CGM, use of ambulatory glucose profile in patients on type 2 diabetes? And these patients were not on insulin. These were the patients who are receiving oral anti-diabetic agent. Still, we had that these are the patients to whom we should put the patients on a continuous glucose monitoring. One more paper which is published from Dr. B. Mohan, and again he was talking that in optimizing managing type 2 diabetic patients on a retrospective, which is again like what we are using Libre Pro, which is a professional on a retrospective continuous glucose monitoring, how it can help and optimizing the therapy for type 2 diabetic patients also. Recently, we published one more article with the time in range is a target in type 2 diabetes, and that's an urgent need. We need that for our patients or type 2 diabetic patients also to achieve a time in range, whether they are on oral anti-diabetic agents, they are on insulin, they are on sulfonylurea. To achieve that, a better is to have a CGM or FGM or a AGP profile for these patients to achieve a better time in range. CGM is an additional asset in this current pandemic. This is one paper which is published in Diabetologia in 2020, and they are talking those patients who are not in ICU. They can be continuously monitored with the help of continuous glucose monitoring, and remotely they can monitor, and they can be monitored remotely by their healthcare provider also. So they need not to meet the doctor, and still the monitoring can be done, and continuous glucose monitoring is really helpful for these patients too. And this is the real-time CGM can be used successfully in a community-based hospital, non-ICU setting to improve the glucose management, and continuously streaming glucose readings may truly be fifth vital sign. So in compared to patient who is not monitoring or getting sugar many times low and high, it's better that these patients can be monitored real time, and they can be also monitored remotely too. Let's look some of the guidelines also. This is the international consensus in 2017, which is talked about the use of continuous glucose monitoring for type 1 diabetes, for type 2 diabetic patients, how frequently, whether they can be intermittently monitored or whether they should be continuously monitored. This has been guideline which is published in 2017, and that was endorsed by multiple associations, organizations like American Association of Clinical Endocrinology is talking that endorsement of CGM, that use of prostral CGM devices should be considered for those patients who are on intensive insulin therapy. It means all type 1 diabetic patients, as well as all type 2 diabetic patients who are on multiple daily insulin injection. For those with a history of hypoglycemia unawareness, which could be a type 1 or type 2 diabetic patients, or the patients who have recurrent hypoglycemia, this is what ACE guideline is talking about in 2020. The ACE is also talking the CGM should be considered as one of the principles for comprehensive management of type 2 diabetes patients. So even not for just type 1 diabetic patient, use CGM whenever it is indicated to assist patient in reaching glycemic goals safely. So what they are talking that yes, in type 1 diabetes, yes, for those patients on multiple daily insulin injection, but it should be also used in patients with type 2 diabetes whenever it is indicated in assisting the patients to reach the glycemic goal. It could be intermittently using continuous glucose monitoring, that what we are using FGM every 3 monthly also. The S has talked about using the CGM in their guideline in this tabular form. Also, you can see here the lifestyle therapy and ongoing glucose monitoring, where they have written very clear cut that CGM is preferred whenever it is indicated. So in their guideline, they had put very categorically that CGM should be preferred as a glucose monitoring device. Use of ambulatory glucose profile for improving monitoring and management of type 2 diabetes. One of the paper which we have written with some of the clinical cases in this. And before 2 or 3 years, before in 2015, we had come out with a consensus guideline for glycemic monitoring in type 1 and type 2 diabetes, along with GDM patients. It was with the Jyoti Dev and Shaukat Sadikot in Diabetes India before 5 years. And then again, in 2018, one more statement, consensus statement was done on continuous glucose monitoring in India with Manoj was the first author, where we have done the recommendation for continuous glucose monitoring. The patient should be, for those who are on multiple daily insulin injection or continuous subcutaneous insulin infusion, to avoid severe hypoglycemia or repeated hypoglycemia, reduce the risk of asymptomatic hypoglycemia or nocturnal hypoglycemia, to treat refractory hyperglycemia, especially when they are fasting, and to tackle large blood glucose excursion in patient with GDM, understand blood glucose fluctuation caused by factors such as exercise, meals, stress, and hypoglycemic treatment, increase compliance of the treatment, promote more effective communication between patient and doctor, diabetic gastroparesis, fulminant type 1 diabetic patients, other special type of diabetic patients who can use CGM to understand the characteristics and fluctuation patterns of their blood glucose profile. And CGM can also be applied to other endocrine and metabolic disorders, including insulinoma. So where the CGM should be used, and this was the guideline which we published in 2018. Recently, from Southeast Asia, the recommendation has been published by Dr. Jyoti Dev, Anup Mishra. I was also the part of it, again by Diabetes India. The time in range and frequency of continuous glucose monitoring, the recommendation from South Asia. We talked about the same recommendation, some of the experts from the other parts of the other countries of South Asia. So we know there are 3 core glucose technology, and CGM at present we can consider it as a complementary but essential for many of our patients. We know that finger stick testing, which is self-monitoring of blood glucose, A1C every 3 monthly, and CGM as and when required for type 1 diabetes, for the patients who are on multiple daily insulin injection, and some of the indication which I talked, if they can afford continuous glucose monitoring, will really benefit them. But those who can't afford continuously, even intermittent, using continuous glucose monitoring is also helpful for those patients. Just to give an example, one of our patients who was on triple drug already, and he had come with the HbA1c of more than 9, you can see all his sugar reports are uncontrolled. Patient was to be started on insulin therapy as A1c was more than 9 with triple drug. He was already on sulfonylurea, metformin, and on DPP-4. We explained the patient, then let us start you on insulin, but patient was not ready. So we explained the patient, let us do your continuous glucose monitoring. After 5 days, we call back the patient and we can see that all the reports are high. We changed from DPP-4 to GLP-1 and we put the patient on SGLT2. So now it was a triple oral anti-diabetic agent with 1 injectable therapy of GLP-1. And you can see on next 5 days, the patient was like this, sugar was getting down. On alternate day, we were calling the patient to reduce the glimepiride dose of from 3 milligram to half milligram. So on 6th day, patient every alternate day, we reduce from 3 to 2 to 1 and then half milligram. On 10th day, when patient had come to us, the patient sugar was 99% control with the patients of 9.9 A1C with all sugar reports are uncontrolled. Here patient was glimepiride was off. Now this patient is only on metformin with SGLT2 and GLP injection, which is once in a week. It's a once in a day, which was increased to 1.2 and 1.8. And then later on, we change it to the once in a week. So you can see how useful a continuous glucose monitoring in a type 2 diabetic patients for deciding the therapy. The patient who was supposed to go on insulin therapy with a 9.5 A1C with already on quadruple therapy or triple therapy to be started on insulin, the patient was not ready. Now only on 2 medication and with GLP-1. And after 6 months, significant weight reduction and patient sugar is getting almost 100% control, no hypoglycemia, and A1C was getting less than 6.5. So this is the advantage of continuous glucose monitoring in our patients with type 2 diabetes also. So to summarize my talk, continuous glucose monitoring assists in discovering unknown hyper and hypoglycemia. In observation of glycemic variability, it assesses the percent of time in range or time out of range, which is below or above, severity of hypo and hyperglycemia during day and night. It provides actionable information, which is derived by CGM report. It highlights impact of behavioral variances. It analyzes glycemic effects of new intervention effectively and efficiently, and CGM assists in care for diabetes, which is getting digitalized. CGM enhances patient self-management, adherence, and confidence in management of diabetes. With this, I once again, thank you, Dr. Das, Dr. Kanugo sir, and Dr. Jain Panda. Thank you very much.